A very good afternoon to all the dignitaries and colleagues. I'll be very brief though, and first of all, at the outset, I would like to uh, thank all the organizing team members, especially Sareen sir and Professor Umesh Kapil sir, who have given me this opportunity to give this brief keynote address and share my views and opinion about the disease burden of NAFLD in India. And with that, I would like to begin my presentation. And before beginning, I would definitely give my regards to all my seniors, Dr. P.K. Singh, Professor Sarman Singh, my senior, Dr. Vikas Bhatia. He had been my senior and an eminent guide, Dr. Ajay Duseja, and all my dear colleagues and fellow beings of the society of ILBS and all the people who are associated with NAFL as well as the participants. The first and foremost thing is, like Sir has already mentioned, that the main important thing about the fatty liver disease is that people are unaware of it, though it is very commonly seen, and it is the most frequent of all the chronic liver diseases. And also it is the most common cause of end-stage liver disorder. And it may be present in up to 75% of individuals who are suffering from obesity and type 2 diabetes, and present in 3% of children, and more than 50% of obese children will have NAFL. So this is a figure which is really shocking, but most of us are unaware of it. And that is why probably we need to create more awareness. And I'm happy that ILBS has taken up this initiative under the guidance of Sareen sir and Kapil sir, that they are incorporating other organizations, aims, and other institutes, so that we can create and go into the depth of the population and community and create awareness, as well as bring about various issues which are related to NAFL. Basically, I think it has been already mentioned that it is accumulation of fat in liver, wherein there is absence of excessive alcohol consumption. This I think Vikas sir has already mentioned, so I'm not going to go into the detail. Just brief on how this thing goes further. Like when the normal liver, there is some because of the dietary factors or drug factors or any other causative agents, which is again we are not sure of what is the cause, but it leads to simple steatosis. And because of the adipose tissue inflammation, gut microbiota, plus the oxidative stress, hepatocyte, and hepatic inflammation, it would lead to hepatitis, steatohepatitis, which is also called as in short NASH, and then further leading to fibrosis or cirrhosis, and further may lead to hepatocellular carcinoma. Now, this slide again shows how this steatosis would lead to steatohepatitis. Now, this is the condition which is reversible. That is, steatosis may, reverse back to the normal liver. But once it changes from here to here, then the reversibility is again a questionable thing. And then further, it leads to fibrosis, cirrhosis, as well as hepatocellular carcinoma. Now, these are various factors which would aggravate or lead to the progression of NAFL into NASH. That is genetic predisposition, dietary habits, insulin resistance, gut microbiota, and lipolysis, as well as inflammation. Again, I'm not repeating the slides, but natural history of disease, if we see, again, 12 to 40% of the cases turn into F1, that F1 to 2 fibrosis, that is NASH, 5 to 15 into the severe fibrosis, And then further, it may lead to cirrhosis in 1 to 3% of cases, leading to hepatocellular carcinoma. So these are F1 to 2 and 3 conditions, and then finally cirrhosis and hepatocellular carcinoma. This is the end stage, and there, in these cases, you can have here, this hepatic transplantation, liver transplantation, till the fibrosis or severe. But here it is again the end stage, and that is why we should be bothered about it. Sir has already told you the load of the disease, prevalence and incidence. So I'm not going into the detail, but yes, definitely these are the interrelated factors why we should be bothered about it, because NASH can remain asymptomatic for years, and we would come to know about the disease when the patient undergoes cirrhosis or has got the signs and symptoms of hepatocellular carcinoma. If we see the epidemiology, it is very diverse, affecting all the ethnicities, both the sexes. Most of the time, the cases are unreported or underreported, and there are limited studies and research undertaken to find out the exact incidence and prevalence of NAFL. And that is why probably we should be focusing on it, because right now, though the disease is there, but we are not aware of its exact incidence and prevalence. But otherwise, if we see the existing data, we will find that global prevalence of NAFL is as high as 1 billion, and of whom nearly 25% would progress into NASH. It has increased in the last 20 years, and the diagnostic test again remains the gold standard as liver biopsy. And we also have other tests which are non-invasive, that is hepatic USG, CT, and MRI. The population-based studies are needed further to know the estimates or the prevalence of NAFL in the general population, which we are lacking. Some of the data which is existent again shows that 2 to 9.6% of the children do suffer from NAFL. The pooled prevalence of NAFL globally is 25.24%, with the highest prevalence rates reported in the Middle East and South American countries, and the lowest one in Africa. Now, this is a slide which shows that the highest rate is in South America, which is 30 to 30.45, and Middle East 31.79, and in Africa it is lowest, that is 13.48. So definitely here, I think we need to put up our efforts to enhance the research. Why it is so high in South America and why it is so low in Africa? What are the reasons? What are the factors which are leading to the high prevalence of the disease in these areas? In Asia, if you see, the burden of the disease is increasing fast, and the prevalence in India has been shown by various studies to be 9 to 32%, in the range of 9 to 32%. And this figure, which just clearly depicts that the male and female ratio, if you see, 24.6 is male and 13, almost 50% in female. Various prevalence data of NAFL in India, which has been shown by various authors. So here you can see that fatty liver, which has been, seen in 39 individuals, and in a study which by Amar Purkar, it is 16.6. There are various studies. I am just going to brief you about the various epidemiological factors, so I'm not going to go into the details. In general, I would just tell you that in India, the prevalence of NAFL varies from 9 to 35%. And the true incidence, again, we are not aware of it. So it is unknown. And in a study which was followed up, and the incidence of NAFL in this case by USG was found to be 12%. In Asia, 13.5%. Again, the approximately it is same. The risk factors which are related to it are a lot of risk factors are associated. The important ones are insulin resistance, central obesity, dyslipidemia, and hypertension, and of course diabetes also. And this is just the tip of iceberg which we are talking about. The risk group in India basically are three more important factors which are associated with it. One is the diabetes, hypertension, cardiovascular disease, as well as other things which are associated with NAFLD cases are polycystic ovarian syndrome, sleep apnea, cancer. Besides this, there are other factors also which are associated with all the high risk group who were suffering from NAFLD. And the main important one is metabolic syndrome, which people are talking a lot about it. Since metabolic syndrome, as all of us know, the causative agents we do not know, we are not very sure of, though there are associated factors related to wide variety of causative agents, but still we are not aware of why it is caused. And thus, the role of lifestyle management and lifestyle issues and lifestyle, we should say the focus on the lifestyle and the research on lifestyle and its management becomes all the more important. These are the various factors which are related to NAFL or helps in the progression of NAFL. The environmental factors, the genetic factors, obesity, resistance, hyperlipidemia, inflammation, everything leading to NAFL. Now, again, the suspected risk factors associated with it are hypothyroidism, hypopituitarism, hypogonadism, obstructive sleep apnea, polycystic that I have already mentioned, total parenteral nutrition, excess fructose consumption, rapid weight loss, and of course the present genetic involvement and the gene PNLPA3 and TM6SF2 gene, which has been associated with these cases. And now, Journal of Clinical Experimental Hepatology in 2012 have shown that the primary risk factors, if we see, type 2 diabetes, genetics, obesity, this I have already mentioned. Along with that, we have secondary risk factors, wherein age also is a causative factor or health, say, or associated with NAFL, gender, family history, sleep apnea, and this medications and environmental toxin at the same time. Metabolic syndrome, if we see, it increases the risk of NAFL to 4 to 11 times. And majority of the patients with NAFL are obese and have nearly five-fold higher risk of developing steatosis. If we see diabetes mellitus, then 69% prevalence of diabetes mellitus in cases of NAFL have been reported. NAFL consistently is associated with dyslipidemia, that is 27 to 92%, and hypertriglyceridemia in 62%, with low HDL cholesterol level, 54% of NAFL patients are observed. Obesity is definitely known to be the risk factor. And one more important thing which has been associated is BMI, that is high percentage of body fat, all of us know. But again, they have shown that despite of the BMI to be of the normal value, lot of Asians who have got the central obesity, they are, as at risk of developing NAFL. And the elevated cholesterol, hyper TG, along with the central obesity, it helps in the progression of NAFL into the further cirrhosis and hepatocellular carcinoma at the same time. It increases with age. And here we can see that, again, this is a variable data. Gender as such has got no role, but in case of India and Asian countries, we have already seen in the map also that the male to female ratio is almost 50%. That is 50% of women are suffering, whereas males, like here, you can see it is 31% in men and 16% in women in Asia. Diet is an independent risk factor, and cigarette smoking is again an independent risk factor, but again leading and predisposing a person for developing insulin resistance. See, all these factors are directly or indirectly related somewhere or the other for the development of NAFL. And if we see the area-wise distribution, it is more commonly seen in urban areas, again related to lifestyle changes. And of course, gut microbiome is also associated with causing NAFL. Then, proportion of comorbidities in obesity. These are the comorbid conditions which are highly associated with these patients of NAFL. And here also, if you see, this study was done in ILBS, and they have shown a pattern which shows that hypertension, obesity, and diabetes, wherein diabetes has been very highly, commonly seen in all the most of the cases of NAFL as compared to the obesity and hypertension. So somewhere diabetes or metabolic syndrome in general is definitely associated with it. These are all again the things which I'm not going to tell. Yes, pediatric NAFL, the prevalence is again increasing in developing countries, and this is again more so in adolescents, especially in obese population. And in India, we will see that in Mumbai, 62% in overweight and obese children, fatty liver was found. Whereas in Kerala, it was 60% in overweight and obese children. In Delhi, it is 62. Now, this is not a figure where we should be, happy to see. We need to do a lot of work, and a lot of gaps are needed to be filled up. And this is where the role of community physicians and other people, doctors and researchers, comes into play. Again, I think my other co-speakers are going to speak about it, about the lean NAFL and the obese NAFL, where in which happens in non-obese and obese people. Then what is the difference? So I'm not going to go into the detail. And the lifestyle modifications and weight reduction is again a cornerstone and the strength of pillar in cases of NAFL, especially in the earlier phases. And what I would request from all the members and the organization as well as the participants, that few things which we need to take care of when we consider the NAFL and other hepatic manifestations and complications. Uh, that number one, we need to do some incidence and prevalence studies related to NAFL, which is lacking. I think it is lacking globally, and India, very few studies have been done. So, number one is we need to focus upon the research. So, all these organizations and issues can join hands together in creating some good research projects wherein we can find out the incidence, prevalence, and the associated factors besides the factors related to metabolic syndrome or lifestyle diseases. And then the management of lifestyle diseases. Second thing here also we need to focus upon. And the third one is the role of Ayush. The role of Ayush also needs to be studied, and the role of Ayush in management of NAFL and prevention also. Plus the role of increased fat intake, the food additives and preservatives, and food coloring agents, pesticides and food, and pollution. These are the areas where I think we should, focus our research and try to find out what are the important causative factors which may be associated directly or indirectly, leading to NAFL or helping in the progression of this disease. Plus, we also need to participate and integrate the National Health Program along with Ayush, and creating awareness again becomes one of the important aspect of all these joint hands. And I think as a community physician, I definitely would be interested that we have some documented figure in terms of incidence and prevalence through good research projects, number one. And number two is integration with various national health programs, inclusion of Ayush, and trying to find out other innovative ways and means wherein we can sit together in a common platform like this and deliberate upon NAFL and how to prevent in India, in a country like India. And I'm really thankful for the organizing team. Thanks a lot for your giving me this opportunity. Thank you very much.